Welcome, everyone, to the Modern Day Overthinker podcast. My name is Colin, and I am your host. This week's episode is with Liv Carrow. Liv Carrow is the president of QC Harm Reduction, Quad City Harm Reduction here locally, where I am located in the Quad Cities. I am located in Davenport, Iowa, for those who are listening from other areas. We discuss some of what harm reduction is and what's going on and what she's doing, and what others in the harm reduction community are doing, as well as some of the misconceptions, why she started doing it. She's also a therapist, so we talked about her day-to-day and what she specializes in. She talked about that, and also trends that she's noticed with some of her patients. So that was very interesting. The whole conversation was interesting. A lot of great perspective and a overall good conversation. So really don't need to explain much else on this episode. It's a smooth one. I'm really glad Liv took the time to come over. We had never met in person. She came over to a stranger's house. So shout out to her for that. I'm glad we were able to have a great conversation, an informative conversation that I think everyone can appreciate. So without further ado, this is episode number 56 with Liv Carrow. Welcome, everyone, to the Modern Day Overthinker podcast. My name is Colin. I'm your host. Welcome if you're watching on video. This is the first time doing video, so bear with me here. Today, I have Liv Carrow in the studio today, and which I can say in the studio today because I'm actually using the room that I wanted to make my studio, so I appreciate you being here and taking some time on the Sunday. I'm glad we didn't do it later because of the Super Bowl. I didn't know you were from Philly, so...
Yeah, I mean, I'm from Trenton, which is like 40 minutes away from Philly. But
yeah, it's close enough.
It's like we're Philly team city, you know.
Yeah, who else would you root for?
So, yeah, not New York, that's for sure.
Not New York.
No.
So when did you migrate to the Quad Cities then?
I've been in the Quad Cities since like 2016.
Okay.
I moved to Iowa City in 2015. Was there for a year and then came out here. Following a golden goose, basically, you know, like I had a relationship that kind of got me out here, and then I ended up staying for lots of reasons, but mostly because I like living here.
Yeah,
it's good. It's a change of pace for me, but I'm sort of like here now.
Yeah, you're locked in. Yeah, because once you get involved with something in the community, it's not easy to leave, even if you wanted to.
No, I mean, how many times in your life are you going to move cities, you know? Like, it starts getting kind of old, so.
I've thought about it, but I like, now that I have a house and, you know, I've acquired a lot of stuff. I'm just like, just for the sake of moving, I don't want to move.
Yeah, like, I also got a house here, and that's kind of my anchor point, you know, big time. Yeah.
So you are the president of QC Harm Reduction, and that has been your title for how long have you been doing that?
About almost like a year and a half now.
Okay.
Yeah, so I'm the board president. We currently are kind of existing without an executive director.
Okay.
So between different members of the board and the staff, we kind of fill in those functions. So I do a few of the functions of an ED, but mostly right now my main kind of focal point is just getting us funding for the next year to keep getting funding and writing grants and stuff. So yeah, I've been working with them. Yeah, a year and a half I've been president. Before that, I kind of came in and out as a volunteer, and I was also formerly on the board of Iowa Harm Reduction Coalition, which is based in Iowa City and Cedar Rapids.
Okay.
So yeah, I was in the
So that's
board
more
there.
of a statewide thing.
Yep. And that was really, I mean, Kim Brown started Quad Cities Harm Reduction in 2015, I believe. And right after that is when Iowa Harm Reduction Coalition kind of got off the ground. And I mean, really before that, I don't think there was anyone doing it in the state of Iowa. So it's been pretty interesting, like just seeing it get off the ground with like the way that policy has also been going in Iowa in that time frame.
Yeah.
Yeah.
Iowa is one of those. We're one of those states that we play catch up with a lot of things.
Yeah, I mean, it's changed a lot even in the time I've been here, socially and politically, and
Oh, yeah.
a lot of things have changed obviously all around the country. But the level of friendliness toward drug users and drug policy really has been pretty consistently, grade D- here.
Yeah.
We also work in Illinois, which is
Different.
a huge contrast. And in a lot of ways, like Illinois is easier to function in because we are, I can just jump right into this if you want, but like
Yeah.
Iowa and Illinois have really different regulations around naloxone or Narcan and syringe distribution. So basically in Iowa, legally distributing syringes or doing a syringe exchange is like not a thing. Like It is 100% underground if we're doing it.
Okay.
Narcan is also regulated really differently. So basically like distributing Narcan as an org is kind of iffy. It's in a gray area.
Yeah.
While in Illinois state is like providing Narcan, right? And they're also like a big like legal needle state. Like there's state funding for needle exchange, there's state funding for overdose prevention. And then in Iowa, it seems like a lot of that funding gets funneled into like prevention campaigns and sort of like informational campaigns rather than actual outreach.
Yeah. Actual on the ground, like
Yeah.
face-to-face
And
stuff.
yeah, it's just harder to pull off. And on the other hand, though, Illinois has like drug-induced homicide laws that Iowa doesn't have yet. So there's some differences that are pretty significant in this area. Even like stuff like
being
access.
on the border.
Yeah, I mean, it's wild to see how different things are handled in each state and how we have to kind of pivot to meet wherever we're working,
Yeah, that's got to be a challenge.
Yeah,
to put it lightly.
It's far out.
Yeah.
Yeah.
So for somebody who doesn't really know what harm reduction is, say somebody's watching this or listening and they're just like, I have no idea what you're talking about. What is a very straightforward way of explaining harm reduction?
I mean, one of the slogans that I really like to sort of start this out is like any positive change, right? So conventionally, drug and alcohol treatment would focus on abstinence, like complete abstinence, right, as the goal. And harm reduction broadens that focus to be like any positive change that improves health outcomes and preserves life. So like, we deal with syringes a lot because that's actually where harm reduction got started.
Mm-hmm. That's the first thing I think of.
Yeah, harm reduction got started. It kind of came with the HIV, rights, like movement advocacy, HIV advocacy, where that's, in San Francisco and New York. Mm-hmm. There were some groups that started looking at health outcomes for, people with HIV, right? Like, what are the things that are making this spread? What are the things that are making this harder to survive? And obviously sharing syringes is a huge issue with HIV and hepatitis. Yeah. So the idea there, right, like the harm reduction approach to syringe use is, well, obviously people aren't just going to stop using drugs because we tell them to, right? That doesn't work that way. So let's make them healthier. Let's make using drugs slightly healthier and easier to survive.
Yeah, if they're going to do it, have them do it healthier.
Like, people use drugs.
They're going to do it anyway.
We accept that, right? And I think that's the big challenge that harm reduction presents to other methods of treating addiction, which is like, we don't actually need you to stop doing anything. We just need you to take care of yourself.
Yeah.
And we're going to try to like provide means of taking care of yourself and your community, which is, disease prevention, overdose reversal, overdose prevention, education around like disease spread and stuff. So it's a public health intervention. Harm reductionists do recover. Harm reduction participants do recover in the sense of like stop using, but you have to stay alive before you can recover.
Oh yeah.
So that's really the that's another slogan, is like dead drug users don't recover.
Exactly.
So there's like, basically you could say harm reduction is it's a method, it's a system of intervention. It's also a philosophy. And I think the philosophy is the capital H, capital R harm reduction. It's like, it's an approach to looking at drug use and substance use and seeing it holistically in the world, rather than like, this is an individual having a problem. You know what I mean?
Yeah, that is a good way. That was a longer explanation than I needed, but
buckle up. You're going to get more of those.
I love it. I love the detail. I appreciate that.
Yeah.
But one thing, because I've heard, people I'm going to play devil's advocate here for a second, because I understand it, but there's people that are like, that think, just specifically the needle exchange, like you're enabling these users, and it's like they have to look at the bigger picture is how I look at it. Like you're not looking at the bigger picture.
I mean, I think even in a small picture frame, right? Like that is just clearly untrue. Because like what happens when there is no harm reduction, or like when there is no syringe exchange, people are still using drugs at the same rates. They're dying at higher rates, and they're transmitting hepatitis and HIV at higher rates. Yeah, these are stats. Like this is like just the facts, right? So we're not here to say, hey, everybody should start like putting drugs in their veins, right? That is not the goal of harm reduction. No. The goal is to show up in a place where that's already happening and provide services and supplies for people to do that more safely, who are already doing it.
Yeah.
And actually the stats on harm reduction and syringe service providers are so positive, like all over. Like there's so much more, people feel more hopeful. They feel connected to something that they can trust. A lot of people in chaotic addiction, or whatever we want to call it, aren't connected to health providers. They're not connected to social services. They're not safe.
Necessarily taking care of themselves, obviously, because that's not their main.
Right, but also the stigma is so tremendous. You can't get any kind of treatment for anything unless you're, quote, clean. People don't want to deal with you.
Yeah.
Even housing, right? Like housing and mental health services and stuff like that. Like people will avoid it if they're being stigmatized and judged for being in active use. And, if they have dependency, that's another barrier to a lot of kinds of things. Like,
oh yeah.
So there's a lot of stats that show that connecting to an SSP or a harm reduction outreach group will increase your outcomes of like health and safety and like eventually maybe recovery of some sort, and also like just staying alive.
Yeah.
So it's generally seen as a very positive intervention once it's on the ground. But yeah, the enabling thing is like, that's the number one argument I hear against.
Oh yeah, that's why I wanted to bring it up, because I hear it. I've heard it before, and I'm like, yeah.
And you hear that with like naloxone, like Narcan or naloxone, like people will be
What's
like,
naloxone specifically?
Naloxone is the chemical that is the active ingredient in Narcan. Narcan's just the brand name.
Oh,
and that's what we all kind of know of is like Narcan. But Narcan reverses opiates. They kick them off your brain opiate receptors so that you are no longer in an overdose.
Yeah.
And therefore you are alive.
I've known some people that are alive because of Narcan.
Yeah, a lot of people, right? Like it works.
Yeah.
So there's this kind of argument around like, oh, well, if we just are going to Narcan people every time they overdose, then what's stopping them from doing it? And it's like, well, nothing actually. They might do it again, but like they get to stay alive another week or month or year to like determine if that's what they want to do, you know? And I think, I mean, there's just actually no argument against widespread naloxone distribution in my mind. Like, it's like if we had, I mean, a lot of people compare it to EpiPens, but it's like an EpiPen can save someone's life in an instant, and we have the technology, right? It's not even like difficult. You just do the thing, right? You have this medicine, you give it to the person, they are not
And
dead.
there's a couple different ways to distribute it, right?
Yeah, like naloxone has, so we at IHR or QCHR, we have intramuscular naloxone. So it's a vial, and you load a little intramuscular syringe and you inject it into somebody's leg or arm or whatever, anywhere. And there's also nasal Narcan spray.
I've heard about
Yeah,
that too.
so Narcan, brand name Narcan, is a nasal spray. And
Okay, brand name.
yeah, you put it in, like, kind of shoot it in somebody's nose, and they breathe it in, and then
I thought you were saying no loxone, so I was like, what is no?
Naloxone, naloxone.
No, like at the beginning of the conversation,
Yeah.
I'm like, oh, okay, yeah, that is
Yeah.
just the generic name of it. Okay.
Naloxone, yeah, and naloxone's really cheap. It's really easy to use. It's easy to teach people to use. It's, costs less than $1 per vial, I think, to get it out into the community. And like, there's also no side effect from using it. So if you are not overdosing on opiates and you take naloxone, like if
that's a
somebody
good
gives
thing
you
to know.
naloxone, you're not going to get hurt.
That's good.
Yeah. It might mean something else is going on that is bad, but like,
Yeah, but
there's no side effect or secondary input from naloxone that would hurt you. But yeah, I don't know, the enabling thing. I mean, I think that kind of broadens out to like this idea that drug addiction or drug use is a personal moral failure.
yeah,
And I think that's like a big point of challenge, right? That like drug use is a systemic societal issue, and it's also a policy issue. And like drug dependency and chaotic drug use are also like, they're social problems. They are not necessarily individuals' failures.
yeah,
And I think in our culture, we're starting to see a shift toward like seeing that picture, like the big picture of like, why is this happening?
yeah,
The traditional kind of approach to addiction is like, well, you did this to yourself and you need to get yourself out of it, right? With your own willpower and maybe the help of others, but like, it's your problem for you to solve. And I mean, I think the more we see the overdose crisis expand and claim more lives, right, the more it's like clear that that's not really working.
yeah.
It's just not working. Abstinence-based, coercive recovery is not working for everybody. And so, and that's the thing too, like for some people it does work.
Yeah.
For some people, going to prison helps them stay off drugs for the rest of their lives. But most people, they go back to using, and they're at a higher risk group after that,
And some of it has to do with just the mental health crisis too, like we were talking about earlier, like wanting to fix yourself and having that solution, and like, this is the only thing I know that works.
Yeah. And there's a lot of people that encounter drugs before they ever encounter any kind of helpful person.
Yeah.
Like that's just our reality now.
And not hard to find.
Yeah. Right. Like, oh, I can like jump through all these hoops and pay a lot of money to try to see a therapist, and that might not work. Or I can go like hang out with my friends and do what they're doing, and they'll feel better and I'll feel better. And, I think that's a simplified idea, but like, yeah, drugs are really accessible, and effective treatment for them is not.
Yeah.
And effective treatment for the underlying issues is not. And more importantly, I think the situations and circumstances that, encourage or like promote drug use are ubiquitous and like getting more. So, it's pretty bleak actually.
One thing I've noticed from, because I've volunteered at treatment centers around the area, and one thing I've noticed is like the majority of them push like one program, and that's it.
Yeah.
It's like there's one of them, I won't say the name of it, but that I've noticed that kind of gives people more of a broader scope. They're like, you could do this, you could do that, and like they're way more progressive about that. But a lot of these treatment centers are like, this is what we've always pushed, this is what we're pushing, and it's frustrating because it's like even someone who I'm abstinent and
Mm-hmm.
I work a 12-step program, but that doesn't mean that everybody needs to do that or everybody that's
Right.
going to work for everybody. You know,
Yeah.
like people
And
need options,
yeah.
not just, hey, this is the only option. If you don't do this, you're going to die and you're going to keep using. Like
Yeah.
that's ridiculous.
Exactly. And that's a scary setup, right? Like, oh,
Yeah.
well, okay, if I fail,
Like the ultimatum approach.
yeah, like if I fail at that, then I have to go back to day 0 and I'm
Yeah.
probably going to die, right? And I have a spiritual and moral failing as a person. It's really hard to like sell that to somebody who's also like in a vulnerable state, right?
Mhm.
Like I think I don't know. I also think, within those rooms, maybe there's some shifts starting to happen around what we might think of as harm reduction stuff, like using Suboxone, for example, right? Very controversial in the rooms.
Very.
Um,
Yeah.
And Suboxone is a really effective harm reduction intervention to treat opioid use disorder, right? Like we know this is fact. It's
Oh, yeah.
it helps people stay alive. It helps people engage in their lives and their communities and their families. Like people on Suboxone can be functioning, healthy, happy people.
Mm-hmm.
And there's no imperative to get off of it, right? I think that's like there's this idea that we should be moving toward a state of like pure abstinence from all chemicals, and that might not be realistic for everybody.
No.
We only have so many years on this earth. Like, how much better are we getting?
I mean, I'd say, you could see that as like I take medication for my anxiety, depression, and I talk about it. I don't talk about it all the time, but I've talked about it in the rooms. And there's some people, not as many, more people are progressive about it and they understand, like, I'm getting this from a doctor. Like, they're prescribing it to me. I'm taking it as prescribed. I'm not, like, abusing it. I'm trying to resolve my mental health issues and make it easier to live with them.
Right. Like you want to be alive.
Yeah.
And you want to live a good life.
Yeah.
And meeting a standard of perfection that existed, that was kind of invented like some century ago.
Yeah, it was a while ago.
May not make sense for us now, like I think we have so much more evidence around neuroscience. Like we have imaging, we have ideas about genetics, we have like all these theories and evidence around trauma and how that affects our brain development. And like none of that existed when the book was written, right? Or like when the earliest days of mental health were invented. Like all of this information we have points at like, there is neuroplasticity, there is healing, there is change that can happen. And also like some people don't get a chance to do that, around opiate addiction specifically. Methamphetamine addiction as well. It can cause some pretty significant brain change. That's like, I mean, I hate to say it's like, you can't pray it away, right? It's real.
Oh, no.
And there's things that we do know how to do that can help people live a good life, whether or not they're using intensively, occasionally, But yeah, a harm reduction example, like Suboxone's one, but also just like what we would call California sober, right?
Yeah.
So people that they quit drinking or using heroin or whatever, but they'll stick with weed and use weed sometimes or all the time to kind of help them feel better. And is that sobriety? No. Is it abstinence? No. But is it like keeping that person safe and alive? Maybe.
Yeah.
Probably.
Yeah. And some people can do that and like,
yeah.
I know some people who can't smoke weed. I know people that have to be abstinent from all that stuff because they can, like, it doesn't matter.
Right.
But
It's
there's
anything and everything.
Yeah, it's all or nothing.
Yeah.
But there's people like, hey, maybe I just should not do heroin anymore and I'll be fine, or not drink anymore. That was like,
yeah.
Or
maybe I should just not drink liquor anymore, or like those. I mean, I think the all or nothing thinking is not a friend of progress, right? So like progress, not perfection, is kind of like, it's a 12-step slogan. It's also I could say that's a harm reduction slogan, right? It's like any positive change is any positive change. One thing I just thought of is a really great, like, if you have to like sell harm reduction on somebody, you can be like, well, seatbelts are harm reduction, right? Like a seatbelt in the car is still dangerous. Car has never been not dangerous. But now it's a lot less dangerous because we have a seatbelt and an airbag, and we can drive a car with less risk to our lives and safety and health. So like there's still a risk. We could argue that cars still aren't that great, right? Or like in a lot of big ways, but you can now drive in a car with a seatbelt and an airbag, and like if you get in a bad crash, you're probably gonna live, versus like 50 years ago, you're gonna roll over and die, like in the oldie songs, you know?
Yeah.
And that's like, it's literally like the harm reduction, like kind of in the world thing. Like there's so many examples of this that like work, right? That we think are normal and logical things to do.
Yeah.
Yeah. Yeah, I brought it around out of the swamp there because I'm like, let's not like. I have a huge appreciation for 12-step programs and the help that's available in those rooms, but like, you know, it's not for everybody, as they say.
Yeah, it's if you're, and that's another thing that I hear another slogan you hear in the rooms is keep coming back, because which I think is helpful, because I've had to have conversations with people who just, you know, they keep relapsing and they're just not but they want to stay, they want to be clean, they don't want to use this substance anymore, but they just can't get it. But we don't tell people, hey, come back when you're completely clean, or we don't do that, which is good. And I don't think it was always like that. I don't know if it was or not. I wasn't around. I haven't been around that long, but I think we were more progressive in that way. The rooms are.
Yeah, like I think stuff's starting to shift just to like meet reality where it's at.
Yeah, exactly.
And like really try to get people where they're at. And I mean, that's happening in treatment, that's happening in the rooms, it's happening in mental health. Like I'm a therapist, and conventionally you would say like, well, we don't treat trauma until the addiction is treated, right? Like, you can't treat one without the other. And it's like, well, that's starting to shift a lot to seeing where like, okay, treating the trauma kind of co-occurring with the addiction is important, because if there's trauma and there's addiction, there's likely a strong connection between the two. So you can't really like take somebody's only coping mechanism from them and then expect them to sit still in therapy, you know, or like participate in therapy. That's like, and that's how it was handled. Even in like, you know, even within a treatment center setting, you'd be like, okay, well, first we're going to detox you, and then we're going to like start therapy. And I mean, I don't know, that works, but there is starting to be a shift to being like, okay, well, somebody with a moderate substance use issue can still engage meaningfully in therapy and make change and feel better. And that might actually impact the substance use more than coercing getting clean or quitting drinking or whatever before you engage in treatment. It's starting to change a lot though, because we're seeing like, okay, like that doesn't always work. Let's try another way.
Yeah, because we're all wired differently, and it's just so it's not a black and white thing at all.
Yeah, you could say that again.
Yeah.
And like, you know, all of the ways people use substances, the reasons they use substances, the settings that they use them in, like it's wildly different. Yeah. So coming at it with an approach of like, I'm gonna meet you where you're at. I'm gonna find out what you need and try to give you that. Right. Like that's like, you know, the approach I try to take in therapy, but I definitely think is the harm reduction kind of way in. Like, okay, if you're, you know, let's say somebody's like ticking every box, right? Their life is just off the rails. They're in all kinds of problems and troubles. And okay, what's the thing you really want to focus on? You know, you want to like find somewhere to live? Cool. Let's work with that. You know, like, we're going to work with that.
You got to meet them where they're at.
Yes. And where the motivation is.
Yeah, exactly.
And I think like, you know, really harnessing somebody's motivation for change is actually like, it seems like a big duh, but at some point that was a really radical idea.
Like, at some point, a lot of things were. Unfortunately, but fortunately, things are starting to shift, and people are more open-minded. Most people, I should say, or a good amount of people are open-minded and want to be.
Like, in conversations like this, I mean, I can't overstate how crucial it is that people have these types of conversations, you know, whatever your thing is, right? If it's like if you think harm reduction's what's up, and everyone in your life is like, you're enabling drug users, like you can sit with people and talk to them for 20 minutes and get your point pretty heard, and like I've gotten pretty efficient at like the elevator pitch and the
Yeah.
like
Yeah.
selling this on different levels, but like it's meaningful to me that like we have effective and available resources for people that use drugs. Like that matters a lot to me. So that's why I care. And I'll make you care about it too if you're talking to me long enough.
Yeah.
Yeah. But
So what brought you into, like, what made you passionate about harm reduction and getting more involved? Was it a personal thing, or was it more of just like after volunteering you're like, I really like doing this, I just want to do more of it?
Kind of all of the above. Like
Yeah.
one of my first jobs after college, and I lived in New York City, and I worked at a really big nonprofit that it is a harm reduction nonprofit, and they work with people of HIV and AIDS.
Mm-hmm.
And they were a radical organization that kind of grew out of ACT UP, which is like a HIV advocacy group in New York that did a lot of radical kind of guerrilla stuff, like a die-in on the Capitol steps. This sort of like the images of like AIDS activism you see from the 80s and 90s, like that's ACT UP, and a lot of people associate it with it. So Housing Works grew out of that, and I worked for Housing Works like in the freaking bookstore. Like I just had a job at this cool bookstore in New York, and it was a nonprofit, fundraising arm, sort of like we had thrift stores and a bookstore. And
Yeah.
so I got to know that philosophy and see kind of how it was impacting people. Like our participants at Housing Works, once they finished their program, they were offered a job at Housing Works. So like really like integrating the philosophy to like, okay, we want you to get where you're at. And then anyway, that was my first exposure. But then that was about, what was that? 2006, 2007, 2008, I worked there. And over the next like 5 or 6 years, I just lost a ton of friends to overdose. Just incidentally, like people in my life started dropping and dying from overdose, dying from alcohol, kind of a lot of people real quick. And that got me very focused on like how to prevent that, or how to understand that differently. It blew up, right? Like, so, and at that point too, it was like, I looked around and I was like, oh, well, a lot of people I used to roll with like died. So I guess I'd better think about my own stuff, how am I going to not die?
Yeah.
And I will, just throw in like, I didn't ever get into like using opiates. I didn't get into chaotic drug use of any sort, but I knew that I was affiliating with and surrounded by a lot of that, and had a lot of friends that were deep in it. So it was more like, okay, I want to step back from all of this. And also, why is this happening? Like I was in my 20s, and it's like all my homies are dying. Like my bandmate died, or a good friend, like a couple of good friends, like that I'd known for years. It's just people we went to high school with, like people from the neighborhood, just all of it. And I mean, that's like, that was
this pre-fentanyl issues?
This was the beginning of fentanyl.
This was the beginning of fentanyl.
Yeah.
Okay.
And that's an interesting point, right? Like fentanyl is really the sort of target of like the blame for this. People were overdosing on black tar heroin before that.
Yeah.
But it was definitely,
at the rates.
it's definitely like a lower rate, and it was more associated with like long-term heavy use, whereas one thing I could sort of throw out there is like, one way to harm reductionists refer to the overdose crisis is the drug poisoning crisis, which I think really shifts the burden of responsibility off of the user as an individual. Because we think of overdose as like, oops, I took too much,
Yeah.
and like I overestimated my tolerance, and I took a little too much, and now I'm, whereas like drug poisoning happens when your entire drug supply is infiltrated by fentanyl, right? Like it's all very and not just opiates at this point.
Oh yeah, it's everywhere.
Pills and powders of all sorts are likely to contain some amount of fentanyl or an analog of fentanyl, which gets really interesting. But like, yeah, we started seeing fentanyl, I think maybe, I don't know, 10, 15 years ago.
Mm-hmm.
And that really started spiking these overdoses and continues to do so, especially now that it's in stuff that you wouldn't even look for it, right?
Yeah, like weed.
Yeah.
I've heard.
Yeah, I've heard rumor of it
like
being
a
in weed.
lot, but I've heard it.
Yeah. Well, certainly stuff that's like, street procured benzos and Molly, MDMA, ecstasy, anything like that. Any street procured tablet pills, they are very likely to have fentanyl or some sort of analog in them in quantities unknown, right?
Yeah.
So that's like, and same with like, I mean, any, your traditional kind of bag of heroin or whatever is likely to contain all kinds of shit, but fentanyl is now, the thing we're looking for.
Because even a small amount can cause a lot of damage or lethal.
It's really powerful. And that's part of why it got popular as a cut, like it's cheap. You can get it anywhere at this point. Like, I mean, I don't really know what the global economics of drug trade look like, but it's being manufactured all over the world, and there are trade regulations to prevent it from being imported, but folks are getting around that by like changing it chemically a little bit. So like there's like something like 70 or 100 analogs of fentanyl now chemically that kind of skate under the laws.
Yeah.
And they'll shut one down and then another one pops up. So it's like, it's kind of like the Delta 8, 9, 10 thing. Where it's like, okay, well, this drug is illegal, so we'll make it a little different so it's not illegal.
Yeah.
And that's how it continues to thrive, right? And like avoid detection. And we have fentanyl test strips that exist, and we hand them out, and people are encouraged, to test all drugs, any on all drugs, test them for fentanyl with a test strip. You can order them online. You can get them from Quad Cities Harm Reduction. But even if it's like something you just like got at a party, right? Like I heard an anecdotal story about a local college had some kind of party, and a bunch of kids took like pills together, like rave pills or whatever.
Yeah.
And every single one of them overdosed. And luckily somebody had enough Narcan in the room to get everybody awake. But nobody saw that coming, right? Like these are like 18, 19-year-old kids taking a club drug at a party at college. You'd think that's relatively low risk, but
think so.
You can overdose now from that. So sorry, I'm talking a lot.
No, it's okay.
I keep going. But yeah, my way in was really just seeing it impact my people. And I'm a musician,
It
so
got personal.
Yeah, like music communities got really really hit, and keep getting hit, but it got pretty ugly. So I started thinking about that and learning about it. And then when by the time I became a social worker, I got into social work school in Iowa City, and I saw a flyer for Iowa Harm Reduction Coalition, and I applied as a volunteer to do outreach. And she, the director at the time, Sarah, was like, actually, like, I'm thinking you might want to be on the board. And I really didn't understand that, but I think it's because I just had so many levels of like buy-in on this. Like, I'd done some fundraising experience. I'd done some, living, had some people close to me, and then I was becoming a social worker. So,
made sense.
Yeah. And in school, I got pretty interested in hepatitis policy and how that was affecting people, right? And like just the way hepatitis C is spreading and being dealt with is very interesting if you're a geek about it. But like,
I know it's a problem, but I don't really know.
It's a bigger problem than we are really talking about. Mm-hmm. There's a lot of problems, right?
Yeah.
You got to pick a few.
Yeah, it's tough to narrow it down to what problem you want to talk about.
Right.
But...
like, what's your problem? What is your thing? What is your problem? How are you going to get into it and make some kind of change there? But Yeah, I mean, hepatitis outbreaks typically predict an HIV outbreak. So if you see an area where there's a lot of hepatitis spread, that usually means a few things, right? There's intravenous drug use, there's nasal drug use, there's sharing of equipment, and then there's a lot of maybe affiliated activities like sex work or like things that are also going to increase like contact between people. So if Hep C is spreading in those settings, like you can bet that one person or two people with HIV can really impact that entire place very quickly.
Yeah.
PrEP is a huge bonus here. Like, I don't know if we're talking about harm reduction, PrEP is a medication you can take as a prophylactic against HIV.
Yeah.
So like where there is PrEP, there is way better outcomes there. And PrEP was also maybe like something we could call harm reduction.
It is. Yeah.
Yeah, it's definitely keeping some people from getting the worst of it, right? And like whatever behavior they're doing that's high risk, it lowers the risk, so you can stay alive and still do that thing.
Yeah.
Yeah.
Yeah, that's more PrEP. I've heard. I mean, obviously, more common in the LGBTQ plus community. Like,
Yeah.
there's I forget which nonprofit it is.
The project in the Quad Cities.
The project.
Yeah, and QCHR works with them pretty closely to like refer, anybody that's interested in testing or getting PrEP access. Like, we work with them a lot on that stuff. So yeah, I mean, this community's got some resources. We also lack a lot of resources, right? Like, we don't have a Planned Parenthood. So there's not a lot of like that sort of intervention, right? Like for people that are looking for safer sex or whatever. We're kind of missing that here.
Yeah.
But we do have the project. We have clocking for LGBTQ kids and teens, and then we have the Quad Cities harm reduction and some other stuff going on. But it's never, I mean, in my mind, it's never going to be enough.
Oh yeah, I mean,
like to stop this train. Like, I don't know what the train is
catch up.
even. Yeah. And yeah, it's a little, I don't want to get like really bleak on this podcast.
Yeah, it's one of those things where you got, I mean, you can only do so much, and it's
yeah,
what you're doing and what other people in the community are doing to try to reduce that harm as much as they can, and fix as many problems as they can.
Yeah,
is impactful and is
totally
going to make a difference. Maybe slowly, but at least it's doing something. It's better than not doing nothing at all about it. Looking the other way and be like, well, this is a problem.
Yeah. And yeah, something is always better than nothing. And like something as little as, getting everyone to like get a Narcan training. We'll set up trainings for Narcan in workplaces or schools or whatever, you can also in Iowa, every individual in Iowa is entitled to one free box of Narcan a year from a pharmacy. So like you or I or anybody can walk into a pharmacy and say, I would like Narcan, please. And they will give it to you, or they're supposed to give it to you.
Yeah.
They'll take your name and stuff, but that's basically like anyone can have it. It's legal.
When you say Narcan kit, how much like dose wise do they give you?
There's just 2 in every box, which is sometimes enough.
Yeah, because I've known people that have had to get Narcan multiple dosage.
Yeah, that's something we're seeing a lot more with the fentanyl analogs and stuff, is because they're not as easy. They're so strong, and there's so much more in the system than like the dosing of Narcan is for like what you might think of as like a normal dose of, I don't know, an opiate like strength that you might get at a hospital, right? But we're talking about just absolutely bananas levels of strength and quantity. And that's something that's just like, our kits have 3 doses in them. We often will give people more than 1 kit if they want, just to sort of make sure there's enough around. But yeah, it's a real wild change to try to catch up with. And like, I mean, basically we're doing it on a grassroots, like almost guerrilla level
Yeah.
that is not necessarily like funded or endorsed by any state or local agency. So it's definitely an uphill climb. If anyone's listening from a state or local agency that wants to support Quad Cities harm reduction, like we want to talk to you.
So where's the funding coming from now?
Well, in this year, we actually got a pretty sizable grant from AIDS United, which is a national nonprofit that works with HIV prevention.
Mm-hmm.
They fund a lot of initiatives like harm reduction orgs and initiatives, and this grant happened to be tied to COVID prevention as well.
Okay.
So there was a lot of federal money that was funneled through COVID into grants that were used in like secondary ways. So a big part of getting the grant was how much outreach we were doing around COVID and like getting people like linkage to vaccines if they wanted to, or personal hygiene supplies and masks and stuff like that. But most of all the grant is for just, to fund us existing. We have staff this year. Like start around when I started is when we first hired paid staff to run the program. So that's been incredible. And it's also really like a lot more, there's a lot more stake, I guess, because we need to keep getting funding. So at this point, we're writing grants with different organizations that fund harm reduction, or known to fund harm reduction. There's a few nationally that like are just kind of like, yeah, here you go. We do some local fundraisers. We have some donors. We have some people buying merch. We've had a lot of people throw events and donate money to us from their events, and that's like great. Birthday fundraisers on Facebook, like you name it.
Yeah. We're
kind of like collecting everything we can get our hands on to really just keep existing. It's not even like, I mean, growth is a goal.
Yeah, but right now you're sustaining.
Yeah, like we're at a sustaining, and frankly, like I think what we have going on is actually really impactful. We're able to like work with a lot of people and catch a lot of like areas of need and respond to them. So yeah, we're getting funding from AIDS United. I think we have another 6 months on that grant, and hopefully something else happens in the meantime.
Yeah.
That's the reality of like nonprofits too. It's just like, you're here today, gone tomorrow. Like if the gods deem you unfit for a grant.
Yeah.
But like really super stoked I took that grant writing class in grad school, man.
Yeah. So you went to grad school for
social work.
For social work. Okay.
Yeah.
And then when did you start becoming a therapist then?
I did my internship at a local private inpatient treatment facility.
Okay.
And so I was working with people there doing individual therapy, family therapy, and then treatment and discharge planning. I also ran some groups. So that was my first like real boots on the ground job, I guess. And then I was a therapist in Moline at Transitions, which is a fantastic local mental health. Like,
yeah, I know about
Yep. Transitions is the best. So I worked at Transitions for a couple of years and got my licensure training there, and was working with a lot of different stuff there. And now I'm working virtually. I work from home at for an employee assistance program. So it's like shorter term therapy. I'm really loving it. But yeah, I mean, I don't intend to stop anytime soon with that. That's my job. Harm reduction's my like hobby.
More passion.
It's more of a and it's also like a way to work on a macro level. I think that in social work, there's a lot of people working in direct service and case management and therapy, but a lot of the skills we have are pretty broad. Like you can apply them to policy or like management or administration and stuff. So it's nice to have like a balance like in my profession where I can do that sort of, Yeah.
So I've tried to bring this up as many times as I can on my podcast. I'm glad you brought up employee assistance program. So what is the employee assistance program? Because people don't understand that they even have access to it.
Oh, like how? Oh, yeah. You're like a benefits admin.
I'm a benefits
Oh,
admin,
we're
so
gonna
I'm
get
all about
so nerdy. Yeah.
Yeah, I'm all about talking about the employee assistance program. 'Cause
Yeah.
So many people don't know what it is. They don't realize the
Yeah.
benefits of it.
So yeah, this is a great question. Employee assistance program is a benefit many employers provide. If you work for a bigger company, you almost definitely have it,
Yeah.
or AKA EAP. That's what you'd be looking for.
Yeah.
An EAP is free therapy that your employer has already paid for, that you can access for free immediately, and that's usually somewhere like 5 sessions. So something like 3 to 5 sessions is kind of an average. But the one I work for is virtual, and it's getting very popular, and some employers are offering 20 to 25 sessions a year.
I've seen that, yeah.
Which is like full-blown therapy for
Yeah.
a year. I mean, what I do doesn't usually take all of that time, but if you are having a problem or a crisis or needing to talk to someone, like, and you have an EAP, just do it. It's basically like low barrier free therapy.
Yeah.
That you can just have. And somebody's already getting paid for that, right? They're getting paid whether or not you show up.
Yeah. Yeah.
So yeah, I mean, it's been really wild because the one I work for, it's called Lyra, and we have a lot of big companies that send our clients or send us participants or clients, and it's a huge diverse group of people like that maybe wouldn't even get therapy.
I know about Lyra.
Yeah.
Lyra's awesome.
Yeah.
That's one of the newer ones that I've heard about.
Mm-hmm.
Because they haven't been around for a long time, have they?
No, it's fairly new.
Okay. Yeah,
I'm not really sure if I'm supposed to talk about Lyra on a podcast, but I'm just going to say it's a great place to work, and we offer a really great array of services to people that are already paid for by your employer. So
yeah,
if you have Lyra and you have any EAP, like, chances are it's worth your time. Yeah, I think getting therapy is just this like maze for a lot of people, right? Like,
yeah,
how do I do it?
And that's a good way to get your foot in the door easily into therapy.
Totally. Yeah, because I'll tell you what, therapists know each other, and we're all gonna like be like, oh, go here, go here, go here. Yeah. Yeah, I mean, the access thing is always a question, but I think EAPs help with that a lot.
Yeah, and I try to bring it up as much as possible because it's one of those things like it's just like glossed over because it's a free benefit. You don't really have to enroll in it yourself. It's just one of those things that.
And this is a good thing to point out too, is like there were laws passed roughly 10 years ago that create like health insurance parity for drug and alcohol treatment. So if you are having a hard time and you want treatment for those things, like your insurance has to cover it. It is not legal for them to not cover it. And you can get leave from work to go do that. There's lots of ways that it's kind of protected. And it's still difficult to get in and get good treatment, but like it's more possible than I think people realize.
Oh yeah.
Like the barriers are lower than they are made out to be, I think. Even if you're Medicaid, like Medicaid treatment centers exist and you can get in and do it.
Yep.
Yeah.
Yep. That is definitely true because I've seen,
I should just probably blanket this with our whole entire healthcare and mental health and insurance system is totally a bummer.
Oh yeah.
It is not working well for many people, but within it are lots of people that do want to help.
There are things that you can utilize. That's for sure.
Definitely. Yeah.
They may not be crystal clear. And because some people, avoid therapy or avoid treatment because of just flat out because of the cost or they're afraid they're going to lose their job or.
And there's some legitimate barriers, like, I mean, if you're a single parent, right? Like, going to treatment for 30 days is really going to change your life. In some ways that might not be in your control. hopefully not, right? Hopefully there's somebody that can help, and
Yeah.
there's lots of, jobs too where you can't get that leave or whatever. But I think, one thing that I have noticed changing is people's awareness of it as like a real legitimate problem.
Yeah.
And like, you'd be surprised how many people are impacted by addiction, or have a loved one who has been through it or is in it. And, that's starting to just be like a more normal experience, like that we all kind of have a reference point for.
Like, oh yeah, I've experienced that personally, or I have a friend, or
my brother, sister, parent, aunt, uncle, neighbor, whatever.
Yeah.
Like, it's circling closer for a lot of people, and that's a bad thing, but it also is a good thing for like compassion and empathy, because once you've been through something with your loved ones, like hopefully, you know more about it and what it's like.
More understanding.
Yeah.
So what's something from a therapist standpoint that you've been noticing outside of, I mean, obviously we know addiction's a problem. We've already covered that pretty well. we know that's an issue, but what's something like maybe that you've noticed as like as a trend, that you've noticed a lot of people bringing up, like, oh, I'm really struggling with this specifically?
Like what isn't really, but
yeah, good point.
I guess
That's a tough question.
One way I'd answer that is like there are very few problems in this world that normal, average, everyday people have that can't be solved with like some extra money and somebody to talk to. It's often that simple, right? Like there are problems we face as people that are just like, you need support and you might need resources. Mm-hmm. And I think a lot of my experience as a therapist points me back to like, people don't have enough money, and that creates a lot of stressors and bad circumstances, and they kind of, start an echo chamber of despair. And like more money would help a lot of people out of what we would call mental health problems. Like, but otherwise, I mean, trend wise, like I really think I'm gonna call it out just straight up. I think TikTok is a big problem.
Yeah.
I think TikTok is, I have like really almost conspiracy level theories about this, but like I think TikTok is profoundly addictive, and it changes your interaction with your phone and the world in ways that like I don't think are good. And I've had a lot of people, like one of the questions I now ask at an intake is, what's your relationship with your phone and what apps do you spend the most time using? Mm-hmm. And I will say, like, just anecdotally, the relationship between a lot of TikTok and a lot of anxiety is extremely like relevant. There's something about it.
I feel attacked.
Yeah, I'm sorry.
No,
there is something about how it works where it kind of predicts, it kind of reads your mind a little bit.
Yeah, it's weird.
And it keeps handing you stuff that brings you in. Like it draws you down into like itself a little bit. And I mean, I know lots of people have said to me, yeah, I'll just open my phone and look at TikTok. And then 3 hours later, like I'm still here, and that to me is that is like a substance, right? It is like
dopamine. Yeah.
It is not a healthy or happy way to like spend hours of your day. So if you're finding yourself with a phone problem, like I would take it seriously.
Too. Like you
could be on Reddit, you could be on Instagram. Yeah. But like
the scrolling,
TikTok is different to me because of how the algorithm works, and like how it seems to like, it notices how long you're watching something, like what you scroll past and what you stop on. And then it gives you more of that. Yeah. Like it's that precise. And yeah, I mean, I think phones in general are becoming like, I think we're all becoming aware of how intrusive they are and like how much time they take from us.
Yeah.
And also like money in a lot of ways. Like they're costing money because they're constantly trying to sell you something now. So mental health wise, like I definitely I don't think there's any argument for increasing your social media or phone use. And I think in a few years we'll see like the numbers on that coming clear. Yeah. And I mean, with that comes like a lot of people feel really isolated. COVID has still been, we still haven't really come out of the cloud from that.
Yeah.
And like, there's a lot of people that were totally isolated for actual years, and maybe still are. And like coming back from that, like, what does that look like? How do you reconnect with folks? How do you make new friends as an adult?
Yeah.
Just a lot of people feeling really cut off from each other, and
Disconnected.
yeah, and there's not a lot of places to gather in the ways that like might facilitate that. So it's definitely something I think of as a theme, is like support and isolation and how those can change your outcomes. Yeah, I could go on about like trends. Oh my God.
Social media in general. Yeah, TikTok
Yeah.
is scary. I get it. Yeah.
The other side
I was
of
very
it,
hesitant about
yeah.
getting on TikTok, and
Yeah.
and I know why now.
I wiped it off my phone almost immediately. I was like, this is twisted. Like, this is like the ring from Lord of the Rings, right? Like, you just start getting like, oh, like I need that.
Yeah.
But the thing I will say about TikTok too is there is a trend. I think it's still very popular right now to self-diagnose severe mental health conditions via TikTok videos. Like,
oh yeah.
Big hot point ones are ADHD, autism, bipolar disorder, schizophrenia, borderline personality disorder, and dissociative identity disorder, or like multiple personalities. So there's a lot of people on TikTok making videos about those things that are not experts or professionals, nor are they actual sufferers. And there's been some research studies about it, like surveys of these types of videos, instructing people on their symptoms basically. And just like the amount of false information that was discovered was like unbelievable. So as a therapist, I see a lot of clients coming in who have self-diagnosed with a severe condition or an unusual condition. And they're very convinced that they have it because someone on the internet told them that this is what it looks like.
Yeah.
And I mean, arguments could be made that a lot of that stuff is underdiagnosed, but like,
Yeah.
it's also just really like troubling to try to give. Yeah, I think doctors experience this too, but like trying to be, you're like, I actually did a lot of training and at school and learned a lot and read a lot of books. And now I know more about this than most people, except if you watched a video on TikTok about it, right? Like you're okay. I got it. Like you're the expert.
Yeah.
So that's a
so
personal
overcoming that
frustration that like,
Yeah.
there's just a lot of people making stuff up, frankly. And,
Oh, I know.
it's not always helpful.
Because I'm pretty engaged and becoming more engaged in the OCD community online. Because
Yeah.
I've had OCD. I was diagnosed with OCD when I was like 13. So I've been dealing with that for a long time. But as far as advocacy and I'm trying to make more videos of it online, like from my experience.
Yeah.
Not like
Yeah.
trying to like what you're talking about. But I see, but what happens, and there's a very strong OCD community online. There was recently, anytime there's any kind of article that comes out about OCD and it has misinformation in it, there is a swarm of people that just jump on it and just.
Good.
Yeah.
That's great.
It's awesome.
Because OCD is also one that's so
people don't understand it.
Yeah, like it's misunderstood, and the label gets thrown onto all kinds of stuff in annoying ways.
For me.
Yeah. I think really having it and doing something a lot are very different. And
yeah, you can be obsessed with something and not have OCD. It's pretty normal.
Yeah. Oh, that's interesting. So you have like some connection to other people with it.
Yeah, I've gotten to know people mainly because of Instagram, actually. Not
cool.
even. I have a friend who's a therapist at NoCD. I've been following the NoCD platform for a while. Actually, when I was blogging, did a blog post about them a long time ago before they started doing therapy. It was just an app for a community for people with OCD, and that's how it started. And now they're doing therapy, and now they have funding, and now they have
Yeah.
endorsements. Howie Mandel's their spokesperson. And
Oh my God, Howie Mandel has OCD.
yeah,
Oh
bad.
wow.
Yeah, yeah.
Did you ever watch Monk?
I watched a little bit of it, but yeah.
What do you think about Monk? Has he got it?
Oh yeah. Oh yeah.
Yeah.
Yeah, it's the funniest part about it, not the funniest, but like yeah, just the misconceptions.
Mm-hmm.
I actually read I've made a video and deleted a video about this already. 'Cause and this was the most recent uprising in the OCD community where they were like, we gotta go after this, and it wasn't like post this guy's address. It wasn't like anything like that. Like this guy did an article on. It was an opinion post.
Mm-hmm.
Thank God it was in the opinion section because it was just really bad. About OCD and its ties. He was trying to make a correlation between OCD and extremism. Like extremism, like as in like being either being a terrorist or being like a super crazy QAnon person,
Okay.
or like
Wow.
and trying to put those two things together because
Oh dear.
because with OCD you become obsessed with something, so therefore you can become an extremist. And I was just like, what is going on?
That's so like
It was
off base.
it was
Oh my
such
God.
it was such a reach, and
Yeah.
he referenced like one study done by these two, I don't even know what their credentials are, people in Canada, and I was just like, they're like, yeah, according to researchers and according to this, I'm like, what?
Woof.
It was so frustrating.
Oh, that is the worst though, when there's like one rinky-dink study that's like not even valid, and
Yeah.
people will be like, research shows. Like,
Yeah,
I
one
mean,
study.
God, if there's anything I want people to do, it's understand how to look at a research project. Like how to what's the sample size? What did they do? You know, like
Yeah.
just scanning the, like when you look at an academic paper and you look at the first couple pages, it'll tell you all about the experiment. And if you get good at that, you can basically decide for yourself whether research, in quotes, is like worth your time.
Yeah.
Or yeah, if we found 15 people in Canada were studied over the course of 6 months, like, but we're gonna write an article about it, you know.
And it was yeah, and it's
Oh boy.
so many people, yeah, within the OCD community have gone after that.
Good.
And, yeah, because there was recently I don't even know what the guy did. I think he definitely did something really bad. I think he might have I don't know if he's a serial killer, but he murdered someone or multiple people. I don't know the story, but he used OCD as a defense.
Oh gosh. Yeah.
And I was like,
That's not it.
yeah, I was
That ain't it.
like, dude,
Oh, yeah, and like, oh boy, that's just,
it was a reach.
yeah.
And I think that's what may have sparked this opinion piece.
Mm-hmm.
So like, oh,
Okay, like, oh, we're gonna connect this to
Yeah.
other kinds of extreme acts of violence or
Yeah.
whatever. Yeah. Well, like, you know, intrusive thought style, like that's real, right? Like there's like, but it's unusual for people to do those things.
the thing is, and also in this article, he said, I think I'll give him the benefit of the doubt of just saying this incorrectly, but he said people with OCD have thoughts about wanting to do this, and that. I'm like, nobody wants to do that. There's no want. The thoughts exist. They happen.
They're called intrusive for a
They're-
reason.
Yeah, they're intrusive. They're unwanted thoughts. Like the fact that he said wanted, that was towards the beginning of the article. That was when I was like, I am angry.
Yeah.
Like,
Yeah.
I am frustrated.
Oh man,
This is,
I could see that.
yeah.
Really not. Yeah,
I
not
was like,
working for people.
what?
Yeah, like I guess that's like, you know, really nobody with a mental illness wants their mental illness.
There's been
Or
some
the
some
symptoms of it.
articles about benefits of having OCD, and like,
Oh jeez.
no,
Yeah.
I don't want. I wouldn't wish this on anyone. Like, I don't want anyone to have this. It's not
Yeah.
beneficial to me. It's been very annoying,
I
to put it lightly.
I work with clients with borderline personality disorder, and I'm pretty passionate about it. I'm also trained in DBT, and like I love borderline personality disorder work because it's so stigmatized and it's so crappy to have that diagnosis. Like the system just shits on you for having that diagnosis. And there's people in my life that have had that diagnosis that I'm like, yeah, like what does this actually mean? You know, there's a lot of argument for it to be like, this is a complex trauma response that develops into like somebody's, you know, coping with the world. And we've decided to bucket it as like a personality disorder that makes it really hard to get accurate treatment or diagnosis, but also to like live, you know. But there's so many of those articles. It's like benefits of having BPD, and it's like, yeah, there's no real benefit to this. Like this seems to very much suck and be difficult. And like it's a stretch to say that there's like personality traits that are always there as a benefit, you know?
Yeah.
I don't know about that. I mean, I don't know. Maybe you want to feel, I don't know. Yeah.
I understand
There's
like trying to look at the positives of things,
yeah,
but like
it's not like something you want to have.
No.
It's definitely not something you want to have. And if you have it, you want it to be better.
Yeah.
Like, yeah.
Yeah, the misconceptions of
it's yeah. Well, we're like in the boomtown era of mental health, right? Like this is the moment where it is becoming destigmatized and openly spoken and written about, and like the idea of going to
everybody
therapy.
has an opinion.
Yeah, like so millennials, like I'd consider myself a millennial Gen X cusp person, but like millennials are sort of oriented to therapy as like a fairly normal thing to do.
Yeah.
But younger generations are like, yeah, you just go to therapy. Like it's cool to go to therapy, you know? And there's much less like gendered stigma around it. I think, you know, Gen X and up, you could see like real strong resistance to therapy among men, and like different kinds of even religious groups, like certain religious groups or ethnic groups do not really respond to like, you know, they don't want to go to therapy because there's a lot of stigma in that community, you know,
you're weak or whatever.
Right. And it's starting to shift to be like, yeah, this is a normal thing to do. Mental illness is common. It is actually more common than not. And going to see someone to talk about it is not a problem. But we're in that like real gold rush of like, everybody get on the train, you know, like somebody's got to make some money here. And it's kind of gross, frankly, but it's also like, I mean, on the other side of it, it's like expanding access and expanding, normalizing and destigmatizing is a good thing. I want that. I want people to be able to like get on the phone and call a therapist and get good treatment when they need to or want to. And like, you know, I think we're getting, we might be getting there. I don't know.
In a weird way. Yeah.
Yeah. But yeah, normalizing all this stuff, and it also sometimes gets kind of icky.
Yeah. It's like, maybe you should just not say that.
Yeah.
You're doing more harm than good by saying that. Like,
yeah. Like, oh, it's... And yeah, like checking your facts and checking your sources is always worthwhile, but especially like if you read a rinky-dink article about mental health or addiction, it's probably good to like notice where it's coming from or who paid for it. Yeah.
There's a lot of, it's pretty easy to start a blog and to start writing.
Oh, I should mention this on this podcast because this is one of my favorite arguments to have about harm reduction and drug use is like this idea that, so there's a lot of high profile news articles about law enforcement touching fentanyl and needing to be Narcaned. This is actually like a trend among, it appears to be a trend among law enforcement to create these scenarios where they have, quote, touched fentanyl and then overdosed from touching it. It appears to only happen to law enforcement and no one else.
Weird.
Yeah, it's like nobody else who touches fentanyl overdoses from it. But if you're a cop and you accidentally touch fentanyl and you need to be Narcaned, and go home and take a bath or whatever. Like this is a news story. So this is definitely something I've seen, not just around here. I mean, I think I did see one around here, but like this idea that touching fentanyl can kill you or overdose you is untrue.
It has to be ingested somehow.
Yeah, you have to get it inside your body. So it has to touch a mucous membrane. You have to eat it, inject it, or put it up your butt or your nose or those are the ways in. Into your blood. It has to go inside of you.
Yeah.
So even if you like had a hangnail on your finger and you touched fentanyl with your hand, you are going to be okay. But if, this idea that this happens a lot to cops is very like, it's a very interesting, like, kind of PR decision. Like, cause, it's definitely making a case that like, I think in a roundabout way, they're trying to say like, this is why drug users are dangerous. It's because you might accidentally touch their drugs. And that's why we need to like police them very heavily, Weird. I don't really know what the idea is, but I'm just going to let everybody know decisively and definitively, like I'm kind of an expert, like a little bit, and you can't touch fentanyl and die or overdose, unless it goes inside of your body.
Yeah.
Yeah. Unless you're a cop, apparently.
Weird.
Yeah. Also, if you're overdosing or if someone around you is, you're going to know. Well, if you're overdosing, you're not going to know because you're going to be not conscious.
But somebody's going to know.
Somebody's going to notice that you are unconscious, turning blue, maybe shaking, and, experiencing a bunch of other symptoms. But like these situations of touching fentanyl have not included those factors.
Weird.
Yeah, I don't know. Don't want to get political about the police, but like this is something I've seen that a few times that it's like, yeah, that's not real. It's not real.
Kind of maybe a scare tactic of some sort.
Seems that way.
Yeah. Okay. That's odd.
Quite.
Very weird.
Quite weird.
Well, it's good to know for people that may not have realized it that.
Oh yeah.
If they come in contact with fentanyl, that it's not going to affect them.
Yeah. Same thing with like if you encounter a syringe in the world, it can't hurt you unless you poke yourself with it.
Yeah.
So if you see a syringe like on the playground or in a garbage can, or
it's probably good to grab it with something like not bare hands, but
pick it up with something else and put it somewhere safe, like inside a soda bottle or a detergent bottle or like even sometimes like a thick paper bag, like something so it can't poke through. Yeah, like there's a lot of people that'll like scream and shriek like it's a mouse kind of.
Yeah.
If they see a syringe, and like syringe can't move, it can't hurt you unless you poke yourself with it. So it's cool if you get it out of the way and put it away in a way that is safe. But like a stray syringe won't. It cannot hurt you unless you make it hurt you.
Yeah.
Yeah.
That's good to know. Informative.
Yeah. Just some little PSAs here.
Yeah. Well, we should probably get to the point where, I'm trying not to run over time. I've been that's been a problem since I started recording at home because I'm like, because I used to record at a studio where I would be timed and have to pay extra or they were pretty cool like about me going over time, but I didn't overdo it.
Yeah. This is a much like harder scenario to be like, all right, wrap it up.
I need to watch my time. Yeah.
Yeah.
And it enables me to not have to edit a bunch of stuff too.
Cool.
Because the last podcast I recorded was 2 hours and 48 minutes.
Oof, that's too long.
Yeah, and I like cut it in half.
I'm like a 1 hour or less podcast consumer. Like if it's two people talking and it goes off the rails, like I can't. But sometimes it's a good interview is a good interview.
I like to stick with an hour and a half at the most. Then my sweet spot.
Well, I hope it wasn't too boring.
No,
I can get I know I can get really like geeked on something,
really
and get really boring about it, and people are like, we call this passion.
Yeah, I think people can appreciate that, and it was very informative, and I think people can learn a lot from this, and Yeah, I appreciate you taking the time.
This is my pleasure. And, if anybody needs Narcan or needles or knows somebody that does, or if you want a Sharps container installed at your place of work or business, we can do that too. We can come and collect them.
So for people that are listening that aren't in the Quad Cities,
Oh, yeah.
where most of them are,
yeah.
but there are people that are outside the Quad Cities that listen.
Outside the Quad Cities, I would absolutely look into, if you have a local or regional harm reduction org. Sometimes the public health department will do Sharps containers, but for stuff like needles, Narcan, it's usually going to come from a harm reduction organization. And for the most part, we're out there, we can mail things to people in the region. So like if you're in like a more rural part of Illinois or something and you want to get in touch, we can discuss, what you might be needing and help you out with that.
Okay.
Yeah.
What's the website? Is it just QC Harm Reduction?
On Facebook and Instagram, it's QC Harm Reduction, and I believe our website is odawalk.com or .org. It's odawalk.org. It was originally started as an overdose vigil.
Okay.
So we do a vigil every year on Overdose Awareness Day too. That's a pretty nice event, and happy to field any questions or inquiries.
All right. Well, I appreciate it.